been tasked to talk about managing common hematological problems in pregnancy, and it's actually a very broad topic to try and cover in 30 minutes. So I thought I'll cover two main conditions. One, of course, would be anemia, and the other would be thrombocytopenia. But since it's so broad, we will now narrow it down to one on thalassemia and another on immune thrombocytopenia. So we'll concentrate mainly on thalassemia. So thalassemia and pregnancy, I'm going not, because of the short time, I'm not going to give the basics already, just go right down to how to do it. But just a brief introduction. I'm going to use these terms throughout. I think you're more familiar with thalassemia major, thalassemia intermediate, and all that. But today I'm going to introduce this term that was first implemented by Thalassemia International Federation, where we use the two terms, non-transfusion dependent thalassemia versus transfusion dependent thalassemia. Because the phenotype of each genetics can be can overlap. So by non-transfusion dependent, what we mean is, sorry, but that's my slides are opposite. So that's transfusion dependent means you need regular red cell transfusion for survival. It is a severe form of thalassemia. Most of you know about beta thalassemia major, but in this northern region, be aware that most patients, most of our transfusion dependents are actually severe hemoglobin E beta thalassemia. Okay, then we have a few transfusion dependent HLH disease. Then for the non-transfusion dependent thalassemias, they do not require regular red cell transfusions for survival. So they are milder forms. They may need occasional transfusions, or when they get older, they start needing transfusions. This would be your beta intermediates, your milder hemoglobin E beta thalassemias, and your HLH disease. So okay, let's get it out of the way. Just note on traits or carriers. It's actually pretty high in our country, and also depending on the population. So for instance, in the northern states, will be a fairly common hemoglobin E traits. So yeah, this combination of hemoglobin E beta thalassemias, and if you go to Sabah, there are plenty of beta traits. So there are high rates of beta nature. So I hope to be able to answer these few questions. So can a person with thalassemia have a normal pregnancy? And how to prepare for the pregnancy, what are the risks to the mother as well as to the fetus, when to transfuse, and what are the modes of delivery. So let's start off with the first question. Now, can they get pregnant? The thing about this is because most transfusion dependent will have some degree of iron overload. The fertility is frequently impaired. They have what we call as hypogonadotrophic hypogonadism. The gonads are functioning, it's just the pituitary is not. Okay. So frequently, to get pregnant, they need assisted reproductive techniques. Of course, if they have left ventricular dysfunction, they should not be considered. And if you have the facility, if partner is also a carrier, consider pre-implantation genetic diagnosis, which will not be the talk for today. And for NPDT, fertility is usually preserved, so spontaneous conception is the rule. So your typical scenario will be, say, a 24-year-old gravida 1 para 0 coming at booking at, say, 22 weeks, first time, found to have anemia, and subsequent workup revealed that the patient is actually either a milder hemoglobin E beta thalassemia or milder thalassemia intermediate. Excuse me. So it's generally considered a high-risk pregnancy based on a lot of previous uncontrolled data, but it is true because there are risks to the mother and there are risks to the baby. Of course, there's also a risk of an affected child. Now, this risk can be minimized through pre-pregnancy counseling and evaluation, and it needs management of such patients within the multidisciplinary team. Now, so how do you prepare for the pregnancy? So we start off with a pre-pregnancy counseling. For both, essentially, whether it's TDT or NTDT, if you can catch the NTDT. Okay. Evaluation and eligibility, then of course you need partner screening and genetic counseling, review raw medications, and discussion about risks for ART and pregnancy in TDT, and generally for pregnancy for the NTDT. So there are overlaps. So I'm only going to go through one side and then tell you the differences. So you need to assess iron overload status, cardiac function. Basically for the DVT, you're more if it is well transfused. They are interested mainly in the left ventricular ejection fraction as well as the cardiac iron overload. The difference here is that if it is not well transfused or if it is like an NDDT, you will not need to worry about the ejection fraction. Chronic hemolysis and chronic anemia can predispose a patient to pulmonary hypertension. This is something a lot of people overlook. The mechanism is multifactorial and not truly well understood, but it is quite well documented. Liver function, DDT, you want to again assess the iron. Similarly, for NDDT, there can be fibrosis as well. That's why plus minus fibroscan or biopsy. Bone health, you need to check for thyroid, check for any presence of diabetes, check for heart function. So we can just do a simple calcium and then of course the infective screening. Now the thing to note about all those who are so-called coming undiagnosed, first time HB7, they generally quite asymptomatic. Don't go angially transfuse that. They have a very high risk of alloimmunization and subsequent development of alloantibodies and cannot get compatible blood, with subsequent risks to both mother and fetus in terms of preterm labor, in terms of IUGR and preterm labor. So we now try as much as possible get a full RBC phenotyping as well as antibody screen before you give the first transfusion. Okay, I'll cover that in a short while. And of course, genetic counseling, don't forget that you need to screen the partner because of the risk of an affected child. If you have the option, of course, offer prenatal diagnosis, or even if you're doing ART, if you have the option, consider this. Like I said, I won't touch on that today. Review back the medications. Now, ideally, there should be adequate control iron overload before the patient embarks on pregnancy. In other words, you want to bring the iron in the heart, in the liver, to essentially normal levels. That would be ideal, and the ferritin in the so-called ID range below 1000 is acceptable, but below 300 to 500 is probably an optimal range. Okay. When you read ferritin, those of you who are sending samples to HSD, be careful of the units that you're using. Internationally, all guidelines use nanogram per deciliter or microgram per liter. But our hospital issues results in picomole per liter. The conversion factor between nanogram and nanogram per deciliter and picomole per liter is 2.247. Okay, so if you suddenly see a result done elsewhere that says ferritin 1000 and then suddenly the result done in this hospital or samples that sent to this hospital with 2200, it is actually the same as the last reading. Okay. So anyway, I don't use picomole per liter because when you want to communicate with other people, you need to speak the same language. Okay, but the lab insists on using ISO standards, okay, or SI units. So if you're on iron chelation, before pregnancy, before the patient's actually pregnant, you should switch to a desproximine because it doesn't cross the placenta that much, because it's a large molecule, whereas the variable and the ferricides are not safe. If the patient on bisphosphonates because of the long half-life, so 6 months prior, should stop ACE inhibitors if the patient is on. Because ideally, it all depends on the iron status. If it's not fit, the patient should not get pregnant. Now the thing is about NDDTs, majority are not on any specific medications. But if they are on, these are the things to stop. What I mentioned warfarin here, because NDDT for some can be predisposed to thrombosis. Okay. If you are on acylation, then follow the same principles. Okay. For both give folic acid. Now, try and give insulin. Okay, make sure the vaccination is completed before pregnancy. Okay, the usual. Now, the thing about non-transfusion dependent thalassemia, splenomegaly can get worse during pregnancy as the hemoglobin drops. So that is something, that is one risk to consider. So if it's already fairly big, either you convert temporarily to transfusion dependence or consider a splenectomy. Okay, the rest are the same. So what the risks to the mother as well as the fetus? I already mentioned that the thing to talk about is transfusion requirement will increase, and because you generally have to hold iron chelation, you need the iron levels to be in the optimal range, so that allows the body to continue to build up and not go to the critical levels during pregnancy. Okay, so there's risk of cardiac failure, there's cardiac overload or pulmonary hypertension, risk of algia, risk of preterm labor, especially if they are inadequately transfused. For anti-DP, there is a risk of increasing splenomegaly with every pregnancy. Okay. Then the patients can actually tell you, my spleen getting bigger with each time I get pregnant. Transfusions frequently required. The thing about this is that I already mentioned risk of alloimmunization, there's a risk of cardiac dysfunction if there's malnutrition, risk of thrombosis, okay? And if I also mentioned that before, risk of preterm labor if they're alloimmunized and you can't get blood for them. So the pregnancy itself, you should give supplemental folic calcium, and this is actually your D3 and not your Rocaprol. If there is clinic, you may continue aspirin and penicillin. You need to stop chelation, although in those who are not so optimally or there's somehow got pregnant despite not supposed to get pregnant, then you can actually resume the sponsoring in those with CR after the first trimester. Although these patients shouldn't get pregnant in the first place, but things happen. Also, if inhibitors are really diabetic, you may continue metformin, but you may need to change others. Insulin, skip that. You need to evaluate ideally once per trimester. I think ferritin and liver is no issue. I think cardiac is the issue here. So we generally, practically, it is normal to begin with. No iron overload, we normally don't recheck. But if it is abnormal, then yes, you should. This per standard and then monitor fetal growth. So when to transfuse? Now, of course, if you have PDP, definitely the patient will need regular transfusions. With a pre-transfusion HP of 10, that would be ideal. In other words, before the next transfusion, the trough HP is 10. Okay, the requirement usually rises with pregnancy, so instead of 4 weekly, it might become 3 weekly. It's just an example. For anti-DP, now there's no fixed HP level. You can find data to support lower HP versus higher HP, both with equally convincing results. But generally, we use a few HP levels, maternal, general, cardiac status, and fetal growth. So most centers give about 8, but bear in mind if there are other organ damage, if there's already a large spleen, we will treat it like DBD. Okay. So majority will require at least one transfusion in pregnancy, usually more. Now, I just have to reiterate this again because we frequently miss a lot of patients, especially in the smaller hospitals. They come to us already transfused, and we are not able to do the phenotyping. Fortunately, most of our patients don't develop antibodies, but if you do get one, it might be a nightmare. So, HDH, not so common here, but we do have a few. They can develop hemolytic crisis from infection and pregnancy. This will be a sudden drop in hemoglobin levels. You need to transfuse them up, definitely. You need to hydrate them well. There is a thrombosis despite anemia of, say, 5, 4. We actually anticoagulate them prophylactically, not treatment doses, but prophylactic doses. So if you suspect infection, you need to cover crank neck and consider bacteria. So ceftriaxone is actually quite a good choice. So mode of delivery. It's based on obstetric indications. However, because especially they're under transfused when they are young, they can have skeletal abnormalities. So they can be careful about pelvic disproportion, so you might have to do an elective cesarean section. Now, the Thalassemia International Federation recommends prophylactic dose anticoagulant therapy in peripartum periods. if patient has increased risk of thrombosis, consider throughout pregnancy, and in the thalassemia intermediates, consider from second trimester onwards if you are treating them as anti-DP because they have more hemolysis than your E-beta. So they are actually at high risk of thrombosis and complications to the mother, things like preeclampsia and all that resulting from the placenta insufficiency. Now, what I mentioned corporate banking because they potentially have the children really affected. So in case this child is unaffected, then you have that option of doing a stem cell transplant on the affected child. Okay, of course these are ideal scenarios, not applicable to many centers. Postpartum safe during breastfeeding is desproxamine, but not safe because it can be crossed through the breast milk. Then, this one you already know. The contraceptive advice is because you have a small chelation, then you have to chelate them that well, so you want to space out the pregnancy, you don't want to get another pregnant again, and the iron keeps going higher and higher. Okay? And it's safe to switch. If the patient needs bisphosphonates for osteoporosis, you may restart after stopping breastfeeding. Okay, so summary, thalassemia is compatible with a normal pregnancy. Generally, the most fit will conceive spontaneously, okay? The transfusion triggers are generally artificial, but generally you wait to try and prevent an organ damage, try and make sure there's no, I think I forgot to mention, intrauterine restriction. Okay. The pre-pregnancy and the clinical behavior essentially in previous pregnancy are useful guides. If it's generally uneventful, everything goes smoothly, no problems of enlarging spleen or that, generally it will be the kind of the patient tells you if the spleen is enlarging last pregnancy, be careful we don't get bigger this pregnancy. Okay. So you need a multidisciplinary approach. So hopefully have enough time to just cover IDP very quickly. So we generally take thrombocytopenia from the lab point of view as less than 150. But actually, anyone with a count of 100 to 150 almost never drops below 100, almost never. So as a result, for pathological purposes, if the count remains above 100, we generally don't consider patients having any disorder if it remains stable at that level. So as a result, it's actually more appropriate to consider a level less than 100 for pathology. Okay, so you can confirm the film, this is normal, this one is a platelet clump. Okay. And then the last one is supposed to show you a large platelet cell, which you frequently see in ITP. So the count that you get on the automated counter is actually underestimate, because these are younger platelets which are larger, and the automated counter ignores or doesn't count them as platelets. So let me explain why some ITP, despite a platelet count of 8, doesn't bleed. So, generally, what is ITP? Immune thrombocytopenia. It used to be called immune thrombocytopenic purpura, but we have since recognized that 80-90% actually are non-bleeders. There's no purpura to speak of. So, and we now know it's an autoimmune disorder, so it's called ITP, or renamed to immune thrombocytopenia. We're keeping the same acronym. Okay, so as with all autoimmune disorders, there's a female preponderance in the younger patients, although in older populations there's no difference, but that's not the talk today. So it's a diagnosis or exclusion. There's no confirmatory tests. You need to exclude other causes of thrombocytopenia. So a typical Fulber picture or Fulber film is you see thrombocytopenia, you see large platelets, but no other abnormalities. And the other thing is it responds to steroids or IVIG, although this is not strictly required in definition, because there is so-called steroid refractory ITP and IVIG refractory ITP. Okay? So generally, the autoantibodies targeted towards peripheral platelets and platelets in the circulation, causing premature platelet destruction, typically in the spleen. But occasionally, it can also cross-react with megakaryocytes, but I think that's a bit too complicated to talk today. In other words, it's pretty normal, with the exception of cases where the anti-platelet antibodies cross-react towards megakaryocytes, then you can actually have reduced megakaryocytes. Okay, but the typical one is no, never, and in fact they actually have increased megakaryocytes with increased platelet production, just that it's dropped very rapidly. Okay? To confuse it further, we say it's an exclusion, there shouldn't be other things, but it can coexist as other autoimmune disorders. So, like I said, typically it's primary, but it can coexist with others to make your life more difficult. Okay. So, platelet count pregnancy. Now, platelet count typically falls to about 10% in an uncomplicated pregnancy for various factors listed here, and it declines as pregnancy progresses. Okay, but about 7 to 10% of the fall is greater, and it drops below the so-called normal range. Over 75 cases is mild and unknown. These are your usual gestational thrombocytopenia. Platelets usually do not drop below 70. If it drops below 70, consider as something else. And typically only towards term. About 20% hypertensive disorder, 4-5% only due to ITP. This is from those who have thrombocytopenia. Okay. So these are the so-called non-pregnant platelet count with median here and the pregnant platelet count, the median there. Okay, so there are a lot of differential diagnoses which I won't go through today. So most of the time for ITP pregnancies, either incidental finding during routine tests or from pre-existing persistent or chronic ITP. Like I already mentioned, it is rare 1 in 1,000 to 1 in 10,000. Majority of the other causes of thrombocytopenia. So the goals of treatment for ITP is, for the mother, you want to ensure that the mother does not bleed, prevent bleeding. You want to prepare the mother for safe delivery, and if you want to consider epidural anesthesia, you definitely need a higher platelet count. There's something to discuss. If your center offers routine epidural, it's something you need to discuss with the mom. If you don't, then of course life becomes much easier. Then the baby, there is the possibility of the antibodies crossing over the placenta and they cause autoimmune thrombocytopenia in the newborn. Okay, this is not NATE. This NATE is due to anti-human platelet antigen. This is completely different mechanism altogether. Okay. So if the mother does need treatment, you want to use the least treatment needed to achieve safe pregnancy and safe delivery. So it means it may mean no treatment at all, just observation. And you're not aiming for a normal platelet count, you're aiming for a safe platelet count. Now, when do you worry out? This is, I think I need to bring this up between the bleeder and the non-bleeder. So if the patient is non-bleeder, that means no incidental finding, never will complain of any bleeding. And actually a large proportion of ITP patients are like that, okay? The likelihood of an unprovoked bleed is low even with severe thrombocytopenia, even if it's less than 10. Of course, we will be uncomfortable with that value, right? But that's how ITP is. But there will always be the problematic bleeders, which can even bleed at a platelet count of 50. So the bleeding history is important. So when to worry when you have a bleeder, when there's actual cross bleeding, there's a large ecchymosis, mucosal bleed, or what I like to call wet bleeds in the mouth, in the palate. So there's no clear-cut platelet count to differentiate both. We generally take about 30 as safe for invasive procedures like this, but the patient's phenotype is what ultimately determines whether it's safe or not. Okay, so this is what I mean by wet bleed. This is palatal bleed, this mucosal, this is the mouth, it's the buccal mucosa. Okay. These are risky. They can bleed anytime. So, monitor platelet count of pregnancy. It decreases the pregnancy, but it may worse towards the third trimester. So initially you can monitor them monthly, then 2 weekly, then at term you need to check them weekly. Now this is actually for our national guidelines, which has never changed, and I think most people use the same. So generally the platelet count is more than 20 when they are not yet term. The recommendation is no treatment required, but expect platelet to drop in third trimester. If they are symptomatic regardless of platelet count, or if they has more severe thrombocytopenia, you can start treatment, or you should start treatment, but quickly taper ideally to a dose below 30 milligram per day. Okay, or if it's very low, below 10, we will give IVIG, like essentially this, and you also give metronidazole with below 10. Okay. Now, practically, Okay? Because these are ideal scenarios. Practically, if I see it dropping, even if it's below the day 6, like 80, 50, 40, 30. When you start something, I won't start the full high dose, I'll probably start the half dose or like 20 milligrams just to see the response and just see whether we can maintain at a certain level. And also sometimes towards the patients can have antepartum hemorrhage. So not necessarily related to the IPP, and it also tells me the so-called response to steroids. So these are the guidelines, but sometimes when we see the trend coming down quite rapidly, we do things a little differently from what the guidelines says. So, but if it's before 36 weeks gestation, the platelet counts are not too low. Generally, we don't recommend platelet transfusion. So unless it's below 10 and you're really worried about bleeding, generally we don't recommend platelet transfusion unless significant bleeding, as mentioned here, or invasive procedures. Because you can raise it temporarily. If the patient is not bleeding, you're only raising the count temporarily. You'll be rapidly cleared of antiplatelets antibody, and it's going to be dropped back fairly quickly by 1 or 2 days back to the baseline. Okay? The marrow actually produces more platelets than you can transfuse. So, and then if you keep on giving platelets every day, because every day you repeat the count, you repeat, the next day is still 10, the next day is still 10, so you keep on giving platelets, eventually the platelet can develop either anti-platelet, different type of anti-platelet antibodies, anti-HLA antibodies, and the patient becomes platelet refractory. Means they no longer respond to platelets. Okay? Now, at term, okay, because IP should be co-managed between the obstetrician and pathologist. Mode of delivery is usually based on obstetric indications, but however, because we don't know whether the fetus will have thrombocytopenia, so we avoid vacuum extraction or complicated instrumental delivery. Generally accepted that platelet count above 30, this is in a non-bleeder. To bear that in mind, in a non-bleeder, in an IPP. The count is more than 30 is safe for normal general delivery. The count above 50 generally safe for LICS and LGA. You only consider epidural if the count is more than 80. However, we always have trouble convincing the NS doctors to accept this that counts. Now, if a cesarean section is required for obstetric indication, if you still have a few days lead time, you could just use corticosteroids if it's below that. If it's below 30, then you want to raise it rapidly, then the steroids to maintain, and you want to make sure the patient takes it. So that's why IV here, although strictly speaking, it doesn't really matter. If it's below 10, then it's severe, yes, and it's already at term, you're going to deliver very soon. You can consider addition of the transfusion on top of actually steroids. If it's less than 50 and needs emergency, then you hit everything. Okay. But the platelets, please don't check for post-platelet count, because if you wait, the act of waiting, the anti-platelet antibodies will start acting on the platelets that you transfuse. You'll be cleared by the spleen. You should give it just before surgery. The idea is to create relatively high levels of platelet when you're going for surgery. That itself will help the platelet activation and all that, and the thrombin burst and the clot forms, and even if the platelet count drops later, the clot is already secured. Okay. The secondary, most places have cassette in already. So it should be given just before surgery, okay? Not given to see a high count before you go in. In fact, it's worse. When you go in, the counts have dropped, but you are allowed by the artificially high figure on your IPC. Okay, so other modalities, yes, possible. There are second lines. We can use azathioprine and cyclosporin, generally safe in pregnancy. Anti-D can be used in the RH positive patients. Don't use locum, it doesn't have approval for that, but these are the two brands available in Malaysia that you can use. It actually causes hemolysis. So it keeps the spleen busy eating red cells so that it doesn't eat up the platelets. Okay. So HB has to be good. Anyway, we almost never use that in Malaysia, and we have very limited experience with that. Splenectomy, if indicated, I mean we rarely do splenectomy here. Unfortunately, most of the other agents are contraindicated in pregnancy. Now, the neonate can have thrombocytopenia. Okay, on average, severe thrombocytopenia will come less than 15, and it occurs in a median value of about 10%. Okay, fortunately, this is rare, although there is a risk of ICH, and with mortality there is not zero, and there is no relationship to maternal platelet counts. And if you are synectomized, because synectomy means that the mother cannot destroy the platelets that are coated with antibodies, so the mother has platelets, good counts, but the antibodies are circulating. So that's the reason why it's more likely if the mother is synectomized. Okay, good platelet counts, but the baby is in the mother, but the baby is more likely to get thrombocytopenia. Okay, the only consistent risk factor is a history of sibling with thrombocytopenia. Okay, since we don't know, when you don't know, you want to avoid all the invasive procedures on the fetus, you should check the cord blood platelet count as when the baby has been delivered. No iron injections until you know the platelet count. The nadir is day 2 to 5, that's because the baby's spleen starts to function, increase in function around this time, and usually the platelet starts to rise by 7. If it is severe, you can give IVIG. But do bear in mind, I think the pediatricians know that the thrombocytopenia may last for a few months and never grow up.